when one is in labour, we have what's called sort of a partogram where we, whether it's a midwife, obstetrician, assessing you at certain intervals to see the progress in labour. So yes, that incorporates the cervix, the level of dilatation. It will also incorporate where the baby's head is in the pelvic cavity. If you're in really early stages of labour, the effacement of the cervix, whether it's still thick, whether it's still thin. All of those things help identify women that are progressing on their journey. Mm-hmm. What we don't want to see is over time that progression isn't there. Mm. So in early stages of labour, even the smallest progression may still be enough. It might not mean that your cervix is dilated open, but we've seen other changes that are very favourable. Obviously, as we progress more into active stage, example, if you were 6 and then 4 hours later you're still 6, and then there's sort of other things that we're noticing, we sort of start to question, okay, what is the chances here of this labour just not progressing any further? Mm-hmm. Has this labour stopped, or is there an obstruction, or is there something else that's going on that's not allowing this, such as infection? So we have to use some form of partogram to allow that progression. And it's a guidance there in place, but it's there for a reason, because we know that if someone isn't progressing and we let things go on and on and on and on, yes, we could slowly get there, but are we actually in the background increasing the risk of a hemorrhage postpartum because that uterus is really tired? Or is that baby actually going to cope with that labour very well at the end if we're allowing that labour to really, really slowly progress? An analogy, I guess, is, we have in traffic, we have speed controls. Mm-hmm. We can only go 20 miles everywhere in London at the moment, but that's in place as a safety measure. Yes, we could be allowed to go slower or faster than that, but actually what's that going to cause? Are we going to increase the chances of a road accident? So we have to put some sort of guidance in there, and I think the guidance is fair. Working in the obstetric world, and you may agree from your time in the labour ward, we still give women a good go. And between examinations, the typical examination period is a 4-hour period. If someone hadn't progressed, it's always that discussion, okay, baby's happy. Yes, you actually want to allow a little bit more time because you feel you actually might bounce on your ball a bit longer. Or actually, was there a bit of a period of time where, we could actually allow for a little bit longer trial on the syntocinon. And we could always come to that discussion of considering extra time. It's not a definite sort of roadblock then and there, and we have to do something at that point. So it's there as a guidance, and it's there to help a further discussion if needed. Yeah.
So as you say, it's kind of like a two-way discussion.
100%.
If I really, really want to achieve a vaginal delivery and I do want to wait, and I'm thinking, well, maybe I'm just not like other women. Maybe I'm just, this part of my labour is slower. It's not like you're going to come in and say, we have to deliver you now.
Exactly.
There's always, as long as baby's okay and I'm okay, there's always a little bit of leeway in there.
100%.
What do you say to women then who, for example, she's been at 6 centimetres in the examination before, you examine her again, she's still at 6 centimetres. She really, really wants to have this vaginal delivery and she's not there yet. If she's, when would be your limit? Is there a time when you would say, look, we really do need to stop now? And if so, what would be the reasons for that?
There is always that time as we could let her go 2 or 4 more hours. Over that, that obviously is very subjective to the obstetrician working in that scenario. If there's syntocinon going in the background or oxytocin, where we would definitely say, okay, this is why we would strongly recommend at this point now intervening would be, one, if we're concerned with the baby. And we actually don't think that across that time period, the baby is going to actually cope very well. Or if we're showing signs that actually things are very obstructed or stuck on the inside. So, women can, at 6 centimetres, the baby get very wedged. You might start to have blood in your urine if everything's starting to get a bit stuck, or you might show other signs of obstruction in labour. Your tummy might show a strange shape, or what we call sort of a Bandel's ring, that can occur. And so when we're doing that exam, might notice the cervix is very edematous, swollen. And when we look at the whole picture, we would say, okay, this is what we've found in the examination. You're not just 6 again. These are the other signs that we've seen to demonstrate that actually we're really thinking that this is not going in the direction we had hoped. Possibly it's to consider plan B now. And I think, once again, it's that discussion where women and their birth partners would understand and go, okay, all right, I see now exactly what you're saying. Whether or not I agree with that, okay, that this is what I'm feeling, and we would go from there.
Yeah, absolutely. So it's really not about, obstetricians not having time to wait or just wanting to be out of there by 5 p.m. or anything like that. And it's not about obstetricians not understanding physiological birth and that each woman can be a little bit different. It's not about that at all. It's actually about trying to get the best outcome and trying to diagnose potentially an obstructed labour as early as possible.
Exactly. Yes.
Okay. All righty. So what about in the second stage then? So again, a woman who is like really desperately wanting to achieve that vaginal delivery, she's pushing, and then someone comes in and says, well, your time's up. You've had 2 hours. What's that about?
Yes. I think this is one of the challenging things is that defined level of active second stage labour. And Nice Guidance has their guidance, once again, for first-time mums or multi-parous women when it's their second baby or more. Once again, it is guidance. So it's looking at that real picture. And sometimes, in a first-time mum, it takes a while to get into that rhythm. We start pushing. It's their first time. So actually, when does that time actually start? Is it their first push or is it once they're in their rhythm? So once again, it's that discussion. And I think with active second stage, first of all, we know that running a marathon, you run out of steam eventually. So that's what we're trying to avoid, is that mother actually running out of energy.
Got it.
So at that point when we say, okay, you've been pushing for this long, I always say, how much energy do you have left? How are you feeling pushing? Happy to give you a bit more time if you think you can do that. Looking at the position she's pushing in, we know there's the more common positions, but actually are changing it up. Have we thought about this position that might help that baby get around? And where are we? So yes, that we might be like, oh, okay, it's 90 minutes now or it's 2 hours. Actually, we can see head of the baby. You're going to do it by yourself now. You'll reach that point where we don't have to intervene. So it's weighing up all those factors. And of course, how's the baby coping? So once again, it's looking at that whole picture. Yes, we have our guidance, but it's thinking about that woman in the moment. What does she want? What's she keen to do? And yes, can we do it to allow her that natural birth, which is really important.
Okay. And if we've got a woman at home who's thinking, right, I really want this natural birth, but I'm looking at advice that says you just need to listen to your body in that second stage and do what your body tells you to do. You don't need directed pushing. And then you're looking at other advice saying actually the best way to achieve that vaginal delivery is by doing directed pushing. How can you help her understand which camp she should fall into?
Yes, I think listening to your body obviously is wonderful. Often if you've got an epidural on board, you may not necessarily feel, or you might feel some of the contractions. So you are relying on that team to help guide you into pushing. So when does it occur? When's it peaking? You really want to go for it in that moment. Obviously, if you can feel the contractions, go with it. Go with your body. You can do it in that way that you're going with the flow. It's very almost animalistic in a way. And you can go with what your body is telling you to do. But you've also got a team around you that can help you too. Yeah. So I think it's trying not to overthink it too much. It's like, well, I can, if in that moment, if I can listen to my body, I will do that. But actually, if I've decided on the day to have an epidural, I know I've got everyone in my camp who will be there to help me, tell me what to do. I've got my birth partner encouraging me. Yeah. All of that is super, super, super powerful, but it also should be reassuring.
Yeah. So maybe it's like a tool that you can bring out if you need it.
Exactly.
Okay. So if we've got a woman who really wants to avoid an instrumental delivery, she's been pushing and you come in and you say, well, actually, it's been a while. You have run out of energy. You do feel you're at the end of that marathon. Baby's coping okay, but, we need to kind of think about what we're going to do next. And maybe you do offer an instrumental delivery. And she says, no, I really don't want that. Because there's lots of women who the thought of kind of forceps or ventouses just too invasive, too much. They don't want that. And actually at that stage, they'd prefer to have a caesarean section. Help her think about the way you're thinking about that and what you would advise on that.
I think this is one of the most challenging situations for obstetricians, the midwife in the room and the patient. I would say if you're going into vaginal birth and you do not want an instrumental delivery at all costs, it's rethinking, okay, is this the right pathway for me? Because there can be those circumstances where regardless of how long you've been pushing for, baby decides that it needs to come out. Mm-hmm. And there can be a point where actually you cross the line and it's almost unsafe to do a caesarean section versus a lift out procedure. So, if the baby is on view or your baby is so low that actually to raise it back up through your abdomen carries a lot more risks than a simple lift out ventouse, for example. So it's really thinking about that birth plan and where do you sit. We know, though, instrumental deliveries, a ventouse is very different to a forceps. We know that. They look different, number one, but also they're very different in the way they're used. So, yes, there are cohort women that might say, actually, I want a ventouse, but I'd rather not a forceps. Mm-hmm. So if you're in that scenario where the doctor says, actually, okay, this is the instrumental delivery, always ask, okay, which do you think you'll be doing or what do you recommend and why?
Yeah.
Because that type of discussion is very, very good. It's very useful. It actually questions the doctor. The doctor then thinks about in their head and go, okay, this is my rationale. I'm going to spell it out for you. Everything's very open, but you have an understanding of the baby's position, where it's sitting in your pelvic cavity, and ultimately what's going to succeed in the vaginal delivery. Because as obstetricians, we've chosen the method that is most likely going to succeed for you.
Yeah.
Yes, you can always say, well, actually, I would rather have a caesarean section. And it will be up to that obstetrician to then explain to you whether or not that's still a possibility or where do the risks lie. Because obviously it differs of how low the baby's head is. So if your baby's head's still high and you've been pushing, a caesarean section possibly is maybe it's not that risky versus a high cavity instrumental. Mm-hmm. But if your baby's much lower than that, actually, it may be that it is seen to have a very high risk of bladder injury at that point,
right,
or the baby being quite stuck or low. So it's working out actually where are you sitting in that whole sort of frame at that time.
Yeah.
That will help you also make your decision.
Yeah. So again, it's not about the obstetrician being, obstinate or not wanting to go ahead with your wishes.
Exactly.
It's actually discussing the additional risks that might be there depending on your circumstances.
Exactly.
Yeah.
Yes.
Okay. And finally, let's talk about caesarean sections then,
yes,
because at this point we are now way above the WHO recommendations, WHO recommendations for the rates of caesarean sections. But I think, as you alluded to when we were talking about it in the kind of the scene setting, that because we're now giving women a choice, because we're not just solving for, mortality, we're actually thinking about women's mental health and their pelvic floor and things like that. Perhaps this is acceptable. And just because we've got a higher caesarean section rate now doesn't necessarily mean that that's bad obstetrics. What do you think?
Yes, I just think it's a reflection of choice now. Mm-hmm. I think, women sort of like, it is a possibility. Actually, I see, in a caesarean section, logistics I haven't thought about before here, and namely the date, the time, when your baby's arrived, you might be a scheduler. For you, that might seem favourable. I think it's important when you are considering a caesarean section that you think about, what the procedure is, the recovery involved, the risks, that type of thing. However, I think at the end of the day, that's just where we're at now. Yes, we're over the WHO recommended guidance, but actually, where did that guidance come from? Actually, why is that?
Yeah.
The big question going forward is, well, where will we sit in another 5 years' time? What is this caesarean rate doing? It doesn't mean it's going to keep increasing. And we then have to look at that whole maternity landscape. How are the services then going to cope with that?
Yeah.
Because with caesarean, you typically possibly have a longer hospital stay. It's thinking about the staffing involved, the care, And actually the postnatal side of it, are we then needing to rethink that postnatal recovery to support women? Once upon a time, it still exists, so not once upon a time, but when they go to get their newborn checked, they're going to have to go down the road, in a couple of days' time. Are we thinking more about home visits? How do we cope with that? All of that type of thing. That's actually what we have to focus on going forward. So I think this is a very evolving picture. I'd be interested to see where we sit in 5 years.
Yeah.
Because we might find actually this is our rate now. It's going to be stable. This is where we were at. We might find it keep going up. I just don't know.
Yeah. Okay. And what do you talk about? So you've alluded to some of them actually in terms of the recovery, but are there any other risks that you would make sure that a woman has fully understood before she goes down that route?
I think a huge one is, what are you thinking about for your future fertility? How big do you want your family to be? Because we know with each cesarean, it can become more complex after each one. Namely being, you may be at risk of the placenta previa. We might find, dense scarring on the inside. So it's thinking about what that next one and the next one looks like, and where do you sit into how big you want your family to be. That's number one. I think number two as well is, thinking about that initial recovery at home. We know cesareans can be very straightforward, but actually we know, a lot of the time there can still be things in the recovery period, like a wound infection or things like that you need to take into account. And I think, then looking at that actual consent form as well. So we have a really good published one in the UK that we use standardised now in the NHS. And it does take you through, although they sound horrific, all of the risks. And actually doing it in that 2-stage where you sign it, you go through it in pregnancy, and then you recheck it on the day. That is important because we just don't know, your baby may be one of that 2 to 5% that has wet lungs at birth, that may need to go to the special care nursery. And it's just making sure that you understand that. Yes, there are risks associated with vaginal birth too, but with caesarean section, it's important that you understand all of those elements.
Absolutely. And so if you are speaking to a woman who is wanting an elective caesarean section at term, maybe because she is scared by vaginal delivery, perhaps she's heard negative things about induction of labour, perhaps she's worried that she doesn't want to spend, days and days on an antenatal ward waiting for a place to go onto delivery suite to have an induction, and she's thinking about choosing a caesarean section. What types of things are you going to be talking to her about?
Yes. So, this was one of the more common reasons for maternal request caesarean over the past few years is that fear of that labour pathway. And I think you've highlighted already in your question is actually talking through, well, what is it that you're exactly worried about? And I just say, look, it's not to be obtrusive. Actually, I'm quite interested because I want to know, what is it? Is there, have you thought about X, Y, and Z? I don't want you just choosing a caesarean section because of the noisy ward that you're faced with, in a labour ward. Actually, I want you to think about it for all of the reasons, that you could have it. Because I think that's really important, because there may be solutions or just things that you need to think about. At the end of the day, anyone who fears labour, they will always still have that option of caesarean. We're not trying to talk them out of it. It's more exploring it to make sure that she's having it for the right reasons too.
Absolutely.
But also she's had that informed discussion with a clinician. And I think, look, tocophobia, one of those conditions that it is significant, and you see women really, really affected by that. And I think it's wonderful that they can choose a birth and have that baby they probably feared to have for so many years in a way that actually gives them a pleasurable birth experience.
The content of this podcast is for educational purposes only. It is not intended to replace the doctor-patient relationship, nor does it constitute personalised medical advice. If you are affected by any of the topics discussed, please speak to your doctor or a qualified healthcare professional.